All right. Thank you very much. Good afternoon, good evening, wherever you're joining us from the world. Very excited to be moderating another one of MENASO Education Academy Cerebrovascular Grand Rounds. This is actually the 66th version of this Grand Rounds, very well accepted through the region, and we're actually very, very pleased to discuss an important topic, a topic which doesn't get much attention, but certainly is drawing more attraction and even call to action. So today we're going to be discussing climate change and stroke, an emerging risk factor which we no longer can ignore. So we're going to look at the latest evidence, emerging insights into the impact of clinical climate change on stroke risk, prevention, and patient care. So we have an extremely esteemed panel of experts, and they're going to share their experiences. They're going to share practical approaches, and hopefully we can engage in a thought-provoking discussion. MENASO Education Academy, the purpose is to exchange knowledge and best practices so that we can hope to enhance clinical experience and contribute to better stroke care for the better outcome of our patients in the region. I'm very happy to be joined by my co-moderator who needs no introduction, Professor Mohammad Vase, who is the endowed Ali Charan Professor of Neurology from Aga Khan University. Dr. Vase.
Thanks, Abi. Thanks a lot. So today we will explore climate change and stroke with Professor Carlos Molina, who will present the role of TNK in advancing stroke outcomes. Dr. Maria Khan will discuss extreme heat and stroke in MENA, from epidemiology to clinical action. And finally, Professor Anna Renta will present climate change and stroke, a global call to action from the World Stroke Organization. These are highly relevant topics, and I'm sure you will find them both insightful and informative. The question and answer session will be after the last lecture. Now it's my pleasure to introduce our first speaker, Professor Carlos Molina, who will talk about the role of TNK in advancing stroke outcomes. Professor Carlos Molina is a professor of neurology at the Autonomous University of Barcelona and a distinguished leader in the field of stroke medicine. He serves as head of neurology section and director of stroke at Walid Hebron Hospital, where he also chaired the Walid Hebron Stroke Center. Dr. Molina holds prominent international roles, including positions within the World Stroke Organization, the European Stroke Organization, and the Angels Initiative, contributing significantly to advancement of global stroke care system. He is widely recognized as an international speaker and key opinion leader in acute stroke management and healthcare system organization, and has played a leading role in numerous major clinical trials and European-funded research initiatives. So, Professor Carlos Molina.
So, thank you very much for the support. So, this is my disclosure. I have no disclosures except that I received some honorarium from India the speaker fee for this presentation. So, this why to change. This is the three main pillars. Why TNK is the time for TNK to replace TPA. Not only the superiority, pharmacological superiority, the large amount of clinical experience over the last 2 decades. So demonstrate that TNK is not only non-inferior, but it can be superior in some situations, particular patients with large vessel occlusion. And also there is a regulatory pathway and milestones that have been achieved over the last years, especially the approval of the MENA approval in Europe and the recent approval in the US and other countries. So this is what I mentioned before. The ability of TNK to have is a better thrombolytic, much more specific for fibrin, the longer lifetime, which allows a single bolus administration. This is the story, the journey of TNK across the two domains, acute coronary syndrome and acute ischemic stroke, and how over the last decades, so we were able to demonstrate that the safe dose for TNK is 0.25 milligrams per kilogram, not like in myocardial infarction that is higher. So there were trials using 50 milligrams, then 0.45, 0.4, and then we demonstrated that 0.25 was the best dose for TNK. So here in this slide, you can see how TNK has a powerful role in LBO patients, in particular in LBO patients. As you can see in this meta-analysis for different trials in the pre-hospital setting and also in the acute emergency setting, So the rate of complete recanalization was increasing twofold, from 10% to more than 22% in patients with LBO for complete recanalization. There were patients that were candidates for mechanical thrombectomy, and they demonstrate these authors, and also in the meta-analysis clearly demonstrated that the rate of complete recanalization and good long-term outcomes was increased by twofold in this population. What about the patients with not unselected stroke population? So in these patients, so the ACT trial run in Canada, so unselected population based on a registry embedded in the registry, they demonstrate the non-inferiority of TNK compared to TPA in a randomized open label study. Now, randomized trial, the others two, also in line with this observation, the non-inferiority again of TNK compared to TPA. So in this slide, you can see the impact of all randomized trials over the last decade. More than 3,000 patients have been randomized so far to TPA and TNK in a head-to-head fashion. As you can see, so in these trials, that there was a clearly consistently demonstrated that the dose of 0.25 was associated with early reperfusion in patients with LVO, improved clinical outcome at 90 days, and the rate of excellent outcome was strongly superior in patients treated with TNK compared to TPA, with comparable rates of intracranial hemorrhage. And this is mainly supported by this meta-analysis. It was a landmark meta-analysis published in 2024, comparing all the studies of TNK versus TPA. You can see at the left-hand side of the slide, so there was a superiority for TNK over TPA in excellent outcome. It means the modified ranking scale 0 to 1. As you can see, so this beneficial effect of TNK over TPA was mainly due to those trials using original TPA and not with the biocopy. And also the most important message is all the other important message is that the risk of ICH was comparable in this meta-analysis. So how to select patient for TNK? Now it's easier. So it's like TPA. So we are ready for the transition. So in unselected stroke population, TNK is superior than TPA for the outcome of excellent outcome, modified ranking scale 0 to 1. In LBO patients, in target mismatch, the impact of TNK is robust, doubling the rate of complete recanalization and good outcome. And still, like in TPA, there are some gray areas like minor stroke without disability or with this minor disability, or the oldest patients, or the late time window that right now are under evaluation in clinical trials, the advantage of giving TNK in the extended time window. So all this body of evidence have been clearly reflected in guidelines, showing that the TNK at a dose of 0.25 milligrams per kilogram is not only an alternative, but is recommended over TPA, and this push the transition from TNK from TPA to TNK. And this is an editorial from Anaranta that she's also a speaker in this webinar. The time has come. The time is now. IVTPA. Would you leave? Please go now. It's time for transition. And it was published in 2024 along with the meta-analysis. So there are clear operational benefits for TNK, faster dose to needle time. So also it's less burden for healthcare professionals, in particular nurses. There is no need of pump. And this is not a minor issue, not only in the emergency situation in the hospitals, but also the door in, door out, when you want to transfer patients for mechanical thrombectomy to a comprehensive stroke center. It may help to speed up the process. And also in the door in, door out in Catalonia, for instance, we have this. After different approaches, we were unable to reduce the down to needle time below 60 minutes. After the implementation of TNK, we reduced the door in, door out by less than 45 minutes. So there are also less errors in the dosing because we have this regimen that is not based on the actual and exact weight of the patient, but also we have range. And with this range, we can just, it's more aligned with the real life. So in registry and real world evidence clearly demonstrate that the rates are comparable. So the outcomes are comparable in real life, similar profiles in clinical trials. There is a work of saving. You can see in this slide clearly the comparison between the pathway of TNK and TPA. So there are different regimens. A TPA is typical bolus by continuous infusion. The logistic advantage of TNK is clear, so you don't need the pump, just a single bolus, speed up the door to needle time, and also the door in, door out for mechanical thrombectomy. So in a sense, it's faster bolus, and you can reduce the door to needle time by 50 minutes, improve the door in, door out, simplify logistics without a pump, and in scenarios where the mobile storage units are in place, you can clearly advance treatment and transfer patients safely to the angio suite for mechanical thrombectomy. And most importantly, you can avoid some thrombectomies by improving the rates of complete recanalization, pre-interventional recanalization. So the longer the distance to the comprehensive stroke centers, so the higher the chances to achieve complete recanalization and there would be no need for mechanical thrombectomy in this patient. So this is also a measure of cost saving. And in some scenarios that there is no mechanical thrombectomy, no endovascular program, so it's worth it to have TPA, TNK there when you can just give an extra option for those patients that are potentially candidate for mechanical thrombectomy, but there is no mechanical thrombectomy in place. So you can see here in this slide how the door to needle time, the average in these two studies was reduced by 6 minutes, but in real life studies, real world data show that it's higher, even 10 minutes or 15 minutes, but the door to needle time is reduced by 22 minutes. This is a lot. This was almost impossible in the past. So we tried with different strategy. We were unable to reduce the door into out that way, but now we succeeded thanks to the implementation of TNK. Also, in this slide, you can see the regulatory pathway and milestones that we have over the last years, showing that after the approval of the MENA, so it speed up all the process of implementation. Then the UK in April 2024, there was a marketing authorization and granted in Britain for the implementation of TNK. So the transition was pretty fast in the UK and in the Nordic countries. So the NICE recommendation guidelines recommend tenecteplase as a cost-effective option, not only the price of the drug, but also the improvement in workflows. That was very dramatic. And also you can add in this equation the saving cost of avoidance of mechanical thrombectomy. So as you can see in this slide, the implementation, the transition is heterogeneous all over the world, but I think this is just a snapshot that this can to be updated since in Southern Europe, for instance, is close to it's 50% of implementation of transitional TNK. There are different reasons for that, but for now we are close into the 50%. In the north part of Europe is almost 100%. So it's heterogeneous because they wanted to ensure that the stocking was there, so that there was enough TNK for patients. And now there is full coverage for TNK in Europe and other parts of the world. And this is not only for the implementation, we need to take a look of the cost effectiveness. And clearly, as you can see in this slide, TNK clearly demonstrated this cost effective in different ways, not only in reducing the cost of the drug, but the whole process, the hospitalizations, and the long-term outcome was improved in the Australian study, basically for the avoidance of mechanical thrombectomy. It's not only that you improve recanalizations, the rate of recanalization, you improve the outcome of long term by twofold, but also you reduce the need of mechanical thrombectomy. It has an impact on the budgets, so reducing disability and the quality of life. So in conclusion, this is the time for embracing this transition. TNK represents a paradigm shift in acute stroke treatment, offering equivalent or even superior efficacy, enhanced safety, and substantial saving codes. This is a very powerful transformative workforce advantage, is this transition. So successful adoption requires multidisciplinary collaboration, not only neurologists, ER physicians, pre-hospital setting, and rigorous education. So we need to to overcome these barriers of the inertia, treatment inertia, and there's a lot of centers that they are reluctant to for the adoption, thinking that we are good with TPA, but we can be better with TMK, and system level planning is needed. So in a sense, TMK is ready to become the new standard of care. That's all, and thank you very much for your attention.
Thank you very much, Dr. Molina, for giving us a very high-level overview. And yeah, truly, it is revolutionized how we treat acute stroke, both from an efficacy, operational standpoint, financial. So thank you for that. Like we said in the beginning, we'll do Q&A at the end, and I hope you can stay with us and give us your expertise. So the next topic, I'm very happy to introduce Dr. Maria Khan Junaidi. Dr. Maria Khan is the architect and the lead of the MENASO Grand Round series. She is a vascular neurologist who works in Dubai and Rashid Hospital. She is the vice president of the MENASO Society and recently also WSO board representative from MENA. So a neurologist with plenty of experience and who's taken up an interest in climate. And what she's going to be discussing is what you see, extreme heat and stroke in MENA, from epidemiology to clinical action. Maria, thank you very much. And the floor is yours.
Thank you, Sebi. So are my slides visible?
Yes.
Okay, fantastic. So thank you for the kind introduction. So what we are going to discuss today is, actually, I want to thank Dr. Vase for sparking the interest in the topic for me, by giving me plenty of opportunities to work on climate and stroke. And by the recent opportunity that I had on working on the WSO paper that Anna is going to be sharing after this talk. My job here today is to talk about extreme heat and stroke in the MENA region. And I'm in the next 20 odd minutes, I'm going to basically speak about how heat is an emerging and I think importantly, a modifiable risk factor for stroke in our region. And I say modifiable because I don't think that we can treat heat in the same way that we treat age, for example. There are things that we can do to modify this risk factor. And so what we will basically talk about is a bit of global epidemiology, so you know where the science actually stands. And then we'll talk about the biological plausibility, how heat could plausibly injure the brain's blood vessels. Then I'll show you some of the regional data, and I'll show you where the deficiencies really lie. And then I'll try to end by some practical, things that we can do as clinicians and as, scientists and as people who are the frontline, health providers, to mitigate some of the risks that we have started to foresee, particularly in our region. I'll try to be as honest as I can in terms of the data that we have available, because, and I'll be honest where the evidence is strong and where it's thin, because I don't think that it's important to realize where the data is thin so that we can work towards strengthening, that evidence. So, Bismillahirrahmanirrahim. So why this talk? Why MENA and why now? I think we all agree that stroke burden is climbing across MENA region. And we feel that heat is an under-recognized but a modifiable risk factor. That's the first reason. We also recognize that MENA is warming pretty fast. I mean, we feel it. We may not know the numbers, but we feel that every next summer is hotter than the previous one. There are studies to show that MENA is warming at roughly twice the global rate. The Arabian Peninsula is projected to approach human tolerance limits this century, and I will present to you some of the data in a later slide. And very disturbingly, this is a recent scoping review published just last year by Tatum and colleagues, and they found that there were only 12 heat health studies that exist from the entire Arabian Peninsula, and not a single one of them focused on stroke as a primary outcome. So here's the real, take home from this slide. The signal is real, it is clinically relevant, but the evidence that we have is genuinely early. And we need to act on what we have now while we start to develop the evidence that's there for this important disease. Now, the WSO scientific statement on stroke and climate change that I mentioned earlier and that Anna will be presenting to you in the next talk has a very different signal. Different in the sense that across 97 studies, we found that cold effects were generally stronger than heat effects. Which means that cold tends to cause more cardiovascular disease, it tends to cause more strokes, it tends to cause more stroke mortality. However, with one important difference, we know that non-optimal temperatures are now ranked the 9th amongst attributable risk factors for global cardiovascular disease. We know they're causing 1.19 million cardiovascular deaths and about 21.8 million deaths as of 2019 GPD study. And very importantly, the difference between the high temperature and the cold temperature is the acceleration in the high temperature related cardiovascular death. There was plus 600% rise in high temperature cardiovascular deaths between 1990 and 2019, whereas that acceleration was a mere 36% for cold related cardiovascular mortalities. So that I think is a very important difference that needs to be highlighted. Whereas cold still dominates, heat effects are rising very fast. And MENA is actually a heat story. So if you look at this graph on your screen, the map where you see the age standardized mortality, MENA region is all red, and that is where the highest age standardized mortality is happening related to high temperatures. We have plenty of low SDI hot regions in the Middle East, North Africa, and we are really at susceptible to the effects of these high temperatures. Now, let's talk a little bit about the mechanisms before we get into regional data. So it's important to talk about the plausibility, the biological plausibility of how heat would cause stroke, because without mechanisms, an association is just a coincidence, waiting to be explained away. This is a framework that was published in Nature Reviews Cardiology a few years ago. And while it may look complex, what I want you to take away from this is the breadth of the mechanisms that are there. So the framework is basically highlighting that there are hemodynamic routes, there are inflammatory routes, there are thrombotic or clotting mechanisms at play, there are autonomic routes. They're all operating at once to produce, a milieu which is leading to a state where strokes can happen. Now, carrying on from this framework, and this is a continuation of that, are two distinct pathways where there is a procoagulant state that gets triggered, and also an inflammatory cascade that is triggered, both ultimately leading to thrombosis and subsequently to cardiovascular complications, be it stroke or ischemic heart disease. Now, practically, from a stroke perspective, how do these mechanisms translate? So I tried to kind of organize it the way that we think about strokes. So how can heat injure the brain's vasculature? So when we talk about ischemic strokes, for example, dehydration plausibly could cause hemoconcentration, leading to blood viscosity, hypercoagulability, and platelet activation, causing systemic inflammation. Heat shock proteins get activated, endothelial dysfunction can happen, sympathetic activation happens. Hemorrhagic strokes, on the other hand, a different story is there. Here, it's more of a blood pressure dysregulation, autonomic stress, and, because it recurs, the trigger seems to be rapid temperature change rather than the absolute heat itself. So it is more of a swing rather than a peak that is triggering the hemorrhage. And then, very interestingly, there is the venous thrombosis story, which I'm going to spend some time on, where, again, dehydration, but now driving venous stasis, and a prothrombotic state in the background could just, provide that mechanistic bridge to the thrombosis. And we have plenty of, not plenty, but enough data to support this sort of mechanism. Now, the essential caveat here is that this is not really a settled story. These are all just plausible mechanisms that are largely inferred from physiological and animal data. There was the Gulf clinical cohort, and that data by Salam et al. That I will be presenting in the next slide. They found a summer ischemic stroke excess, but they could not explain it by dehydration markers. The data was pointing more towards a solar radiation and inflammation than rather than just a simple hemoconcentration. So what we are inferring is that, it's the biology is not a simple, just your body getting dehydrated and you just tell people to drink more water in summers and that settles it. It's more complex. It has other factors that are at play, inflammatory factors, and more work needs to be done to understand it better. Okay, so what kind of data do we have for ischemic stroke and heat? Let's start there. So the regional data, these are the 4 studies that I could find, and they are a part of the systematic review that we did. I'll start with the study by Salam et al. From Qatar. So it was a clinical cohort. What they found was that ischemic stroke rises with mean temperatures, and with an absolute OR of adjusted OR of 1.02, and solar radiation 1.26. The ICH pattern was not as consistent, so it was more of a ischemic stroke pattern that was seen, outnumbering hemorrhages. The second study came out of Israel. It was a case crossover study of over 15,000 events. The summer heat raised the risk of stroke and TIA, but importantly, there was a 6-day lag that was shown. So it was not an immediate effect. The strokes were happening after a lag period. The third study, also coming out of Israel, of about 1,100 patients, showed that a 5-degree rise tripled the odds of ischemic stroke in summer. So the odds ratio was 3.1, and in winter, the association went the other way. So the season was actually changing everything. The fourth study is a time series analysis coming out of Kuwait, and interestingly, the adjusted analysis did not reach statistical significance, but the signal was very clear. It was in the same direction. There were more stroke admissions with the summer months. What was interesting is that the ischemic heart disease and all cardiovascular disease were significantly associated with the summer months. It was just the stroke-specific estimate which did not reach statistical significance. So all four data consistently, I would say, showed that warm season was associated with ischemic stroke, and the effect sizes varied, but the direction seemed to be the same. Now, what about hemorrhagic stroke? Well, hemorrhagic stroke behaved quite differently in the few studies that we do have from the region. And this is where the swing and not the peak kind of theory is being realized. The clearest data that we have is coming out of Mozambique, where the study found that a minimum temperature decline more than 2.4 degrees across consecutive days triggered stroke. And this was strongest for hemorrhagic stroke. So the OR was 1.5, and that was and what was convincing about the data was that the effect was strongest in people who had the classic risk factors. So it did show that this was an independent trigger. Of course, the Qatar cohort showed that the ischemic stroke risk was there in that cohort that I showed you, but the hemorrhagic temperature link was not there. So more heat, more ICH relationship does not translate as cleanly for hemorrhage. So what we understand from this is that for ICH, the rapid day-to-day temperature change matters from the one study that we do have, more than the sustained heat kind of story. Now, CVT is actually where the most interesting data is, and where the regional signature is most, I would say, convincing. I'll start with our own data. So this is a study that we did a few years ago. There were 3 centers. One of the centers was my center, where we found that about 50% of our CVT was occurring in the May to September months. We hypothesized that dehydration could possibly be at play here, although we did not use any biological markers, like osmolarity or hematocrit or anything like that to prove that association. Similar findings were found in studies coming out of India, from Pakistan, and from Iran. Summer incidences were high. Different kind of measures were used to see these associations. So, for example, from India, the summer incidence was significantly higher. Younger patients were more vulnerable. Study coming out of Pakistan, again, hot summers in all of these places. Summer peak was again seen. And then the study that came out of Tehran showed that the July to September was twice the number of CVT was seen compared to the December to April months. So the signal here is 4 cities, from 4 different countries, but one consistent pattern was seen, that CVT is clustering in the heat. Now, when you start to see this kind of a pattern, what you can kind of make out is the summer clustering is consistent. A risk factor is identifiable in majority of the CVT cases. We have to give you that. But there is a meaningful idiopathic subgroup that still remains. Heat-related dehydration is a biologically plausible trigger. We talked about the mechanisms. and it may be acting additively even when a prothrombotic state exists. So that needs to be kept in mind. And then, of course, we are lacking direct causal evidence, and that is where our clear regional research gap is, and that's where we need to work. Now, another thing that I think I felt deserved a separate slide is Hajj. And this, I think, is the single most extraordinary natural experiment that exists, in terms of extreme heat cerebrovascular risk anywhere on Earth. Consider this setting. We have over 2 million pilgrims from more than 180 countries who assemble. And in the past few years and over the next few years, we're going to have summer Hajj, where the temperatures are reaching 44 to 45 degrees. I did Hajj 3 years ago. I remember it was July, temperatures reaching 50 degrees on the day of Arafah. This is published, from in June 2024, the Saudi MOH announcement. The 2024 heat wave caused over 1,300 deaths, and 83% of these deaths happened in people who had no air conditioning access. 77% of these, and this is published data, of these patients were above 40 years of age. They identified the peak days. They identified the peak timings. The peak days were the days of Arafah and the days of MENA, where people are out in the heat, and the peak timings were identified. What is very, very interesting is that almost 75% reduction in heat stroke cases was achieved from mitigation strategies, despite rising heat. And this is published data. So what I'm trying to show you here, the caveat here is that the published Hajj data are on heat illnesses and heat stroke. They're not stroke specific. So how do I look at this data? It is the largest natural experiment in extreme heat cerebrovascular risk. It's a major research gap, regional research gap, where we don't know what's happening, how many patients are getting strokes. But the heat stroke shares the prothrombotic and the CNS injury pathway that is very similar to stroke. And I would love to see stroke data, because I know they have a fantastic stroke service now that's running. There is a mobile stroke unit there. The stroke services are amazing, the coverage that's provided. We would love to see what's happening during the Hajj season. And I spoke to Dr. Adil, and we're going to have a separate MENASO webinar, just learning about the experiences during that time. But I think what the learning points here are that the mitigation strategies work. We have identified people who are at high risk. We have targeted mitigation strategies that work. And, this is like an experiment that you cannot reproduce. I mean, it's a natural experiment and you've shown that things can be really taken care of. Now, very quickly, I just want to talk about a few other things like temperature variability. So this is a very important thread that also needs to be picked up when we talk about high temperatures, and variability itself also shapes the kind of stroke you get. So from the Mozambique study, we found that the minimum temperature declines trigger hemorrhagic strokes. And from the Israel study, we found that a larger summer diurnal range, cool nights, were protective against ischemic strokes. So for ischemic strokes, cumulative warm season heat load drives the risk, and the cool nights are protective. And for hemorrhagic stroke, the day-to-day swing matters more. Now, why is that important? Because we are realizing that the MENA's minimum night temperatures are rising fastest. So now we are seeing more of sustained heat without the night relief that was actually going to be protective. So that's another, alarming signal that we need to realize. What's happening to our temperatures? I just want to quickly show you this climate change paper where we realize that MENA is warming at roughly twice the global rate. Arabian Peninsula is the hotspot. And under business as usual, supra and ultra extreme heat waves by late century are going to be an annual occurrence. Half the MENA population by 2100 is going to face annually recurring extreme heat waves. And the night temperatures are rising. So this is what's expected. Recent past, 43 degrees was the average temperature. By mid-century, it's going to be 46. And by late century, it's going to be 56 degrees. So with this kind of hot temperature, the risk is going to jump. So this is a modeling study that came out of Kuwait recently, where they said that it's expected to increase by moderate estimate by 2%, the cardiovascular admissions, by 2090 to 2099 versus baseline, and in an extreme scenario by 4.5%. Now, this may not look like a big figure, but imagine these figures exclude aging population and population growth. So the real increase may be actually higher. And we know from the GBD study that the cardiovascular disease burden is rising in low SDI hot regions. And that's what MENA region is. And unfortunately, we do not have MENA-specific stroke burden forecasts to tell us, we just know that we are heating up really fast. Our numbers, the population growth is really fast. So our stroke numbers are bound to jump. What can we do? So just last few slides on what our role should be. So who is most at risk? Well, elderly, we know from the Hutch data. So elderly does not mean elderly. We know anybody above 40 is a practical marker to start. And we are seeing cardiovascular disease at much younger age in our population. Comorbid cardiovascular disease has to be a red flag for us. Diabetes, hypertension, prior stroke. Migrant and outdoor workers, we see so much CVT in our region. I'd love to hear from other colleagues on the panel and otherwise, so we need a region-specific equity dimension in this. And then, of course, this huge natural experiment every year that gets done, we have unacclimatized, exposed, exerting pilgrims every year who are obviously exposed to this huge. So how can we do this? Pre-summer medication review, review the diuretics, review the antihypertensives, hydration counseling, of course, built into secondary prevention. And then we need to be just extra vigilant around the summer months for CVT. Do we have any signal to suggest that there is a group, a sex-specific increased risk? Not really. So men, we have one study suggesting they're at a high risk for ischemic stroke. No sex difference was seen in the Hutch study, and women were higher heat mortality in Europe. So no clear sex signal, inconsistent data. Some things need to be done at system and environmental level for mitigation, early warning systems. We know EMS surge planning, so deploy and, for summer and Hajj using known clustering, urban cooling and green spaces. We have to do something about this. Built environment, of course, building insulation and ventilation, shaded public spaces, cooling stations. And we have proof of concept. So, during Hajj, layered mitigation cut heat stroke cases by almost 3/4, even though the temperatures were rising. So we know that interventions work, and we need to work on those interventions. So these are busy slides, but what I want to highlight is that there are things that can be done at the bedside. There are things that we need to focus, in terms of research agenda. We need more data to inform better decisions. And then, of course, public awareness needs to be there. Heat exhaustion is not enough. We need to connect somehow that heat may be increasing the risk of people getting strokes. Even though the data is still thin, we need to work on, strengthening that data. And we need to identify our vulnerable population and we need to protect them. So key takeaways: heat is an emerging modifiable stroke risk factor in the MENA region, and the relationship is subtype specific. I very honestly tried to present to you whatever data is available. The burden will grow because MENA is warming faster than the rest of the world, and we need to act now and we need to build the evidence. And I thank you for your attention.
Thanks a lot, Maria, for an excellent, very informative presentation. Now, should I
While
introduce
she's
now?
joining, Maria, I think our experience in Abu Dhabi is the same for CVT. So just looking at a very basic level, for sure, the summer months, or July, August, September, clearly the number of CVT admissions do peak. At least from, the colder, traditionally subarachnoid hemorrhage, they used to say it happens more in winter time. Over here, we've not seen those kind of associations as clearly as when I was in Cleveland, but clearly for CVT, I think it peaks during the summer months. But I think, like you said, dehydration is just the tip of the iceberg, or just one of the factors in this whole milieu which increases the stroke risk.
Yeah. I think we need better surrogate markers to kind of better define the associations. The biological plausibility is there, but that's where these climate data kind of, I mean, the 97 studies that we did eventually include in the climate paper, they're all ecological, very little data that can really establish causation, that's where we are lacking that strength to really endorse this as a real risk factor. But the signal is very, very strong. And this Hutch data is very interesting. I really wanted,
like more data and more in-depth analysis.
Yeah, agreed. And of course, maybe you'll speak about it later, mitigation. What about fasting and all of this, right? That is also a significant component which comes up in our area. How do we deal with summer and fasting and religious preferences? I often struggle with that, especially in people who've had prior CVT, with recurrences. All these do specifically need region-specific data and a good deep dive into these issues.
Yeah. Yeah, that's a very pertinent point as well.
So while she's joining, what is your call to action, at least for MENASO? What can we start with? Or with the MENA region?
I think the clearest, at least awareness part, that this is a risk factor, that recognition, I think is still not there. We hardly ever talk about it. I mean, this is the first time we're having a climate and stroke webinar, to be honest. So I think just that recognition first up is important. And then I think in terms from a purely clinician's perspective, it's important that we recognize for the summer months at least, when we are evaluating from our patients, the medications need to be carefully looked at, dehydration, and on top of it, a lot of them are on diuretics, and so as we are entering into that phase, that becomes important. From our angle, from an awareness perspective, I think heat exposure and how to kind of keep yourself cool during these months, that's important. I think a clear signal needs to go out that we see more of these complications in summers, and you need to keep yourself well hydrated, and because those are things that we can easily do, and then
Yeah, agreed. Dr. Vase, any comments on this is quite closely or inextricably linked. What about air pollution? In air pollution, when you add it to, climate?
Actually, air pollution is a stronger risk factor for stroke, both ischemic and hemorrhagic, especially particulate matter 2.5. So air pollution overall is a stronger risk factor as compared to climate change. Now, climate change, we are learning more and more now, but for air pollution, I think we have a good data suggest. Now we are still working on mechanistic data. For that, I think we should also work mechanistic data for CVT in Arabian Peninsula, because we need to do in-depth analysis of a mechanism that what happens in. It's just not dehydration or the heat wave. It's probably something more than that. So we need to look for that. But I think maybe one seminar on air pollution would be good, because that's a different ball game, and that's a much stronger and impactful indicator at this point. So that's also huge for MENA region. My question is, what were the actual mitigation strategies which reduced the risk of death during Hajj season and heat stroke during Hajj season? Other than awareness, were there like any specific mitigation strategies they applied during those seasons?
I will have to look it up, Dr. Vase, but I think some of those were providing shelters. So the other was that they figured out that 83% of the mortalities that happened in people who were not coming through the proper channels. So they were out in the open, So they were not in sheltered accommodations like they provide. So when they implemented the mitigation strategies, they controlled this traffic. More than half of these people were coming on foot, or they were coming from um, uh, through illegal routes, where they did not have proper shelters and accommodations. So I think that was one of the main strategies, that they curtailed those kind of traffic where people did not come through proper mechanisms, where they had sheltered air-conditioned accommodations during these heat months. And then, of course, when you control the numbers, then you control the hydration and all those things that you are providing for those people. I think that was the main thing.
Okay, thanks. What time is in New Zealand right now?
6, I think.
6 a.m.
It's early.
What about children, Maria? Any data on children and heat strokes in MENA region? Is there a risk of increased stroke risk in pediatric age group?
I didn't get a chance to look that up. But stroke itself, we don't have much data, There's more data. Every time you look it up, it's more on heat stroke, not stroke, common pathways, but...
So some comments while we're waiting. Dr. Kiran Vakar says she worked in Makkah during Hajj season, a lot of stroke patients, especially high number of CVT in females, not only due to temperature, but due to OCP use.
Yeah, that also.
But that's not published yet. It's just observations.
Yeah, they haven't. Today I was speaking with Dr. Adil, and he said that it is such a crazy busy season for them that, they hardly get any time to do anything. I don't know, they properly... I wanted somebody, to join us on this panel to hear their views, but they're very, very busy right now. So,
well, like you said, I think it deserves another webinar, and hopefully we can.
Yeah, very interesting insights,
So, listeners, you can type in questions if you have any. Maria, what type of intake should be avoided in summer for prevention? Like, are there minimum, hydration limits or anything that you saw in literature?
Not really. Nothing in particular.
So how
But
can
the
we
patient
collaborate?
population is, the kind of patients who come in with CVT. I don't know, maybe for you, for us mainly, we see a lot of males, males more than females, but that might have to do with the general demography of Dubai, I guess. We do not find a lot of underlying prothrombotic factors, to be honest. Maybe 50-50, something like that. And a lot of labor in the summer months, I think. That's what gives you this idea that, people are. One other interesting thing that I really want to explore, there is just this Mozambique study on temperature variability, right? There is this other kind of temperature variability that all of us face, right? I mean, we're sitting in this air-conditioned environment at 20, 22, 24 degrees. And then we would step out into 45, 48 degrees, right? And a lot of us face this, anybody who's living in this, Middle Eastern environment, we are facing this sort of temperature variability multiple times during the day. I wonder what kind of impact this kind of temperature variability has on our risk. I mean, I'm sure there are some autonomic effects of this, and we don't drink enough water. I don't drink enough water. I'm sure this is contributing also to a lot of dehydration that's there. And then another interesting thing would be the timing of the stroke, in our part. If you recall, in the last Cerebrovascular Summit, the data that the Dubai EMS presented, most of their strokes were happening in that early hour. Does that have to do with anything? I mean, these temperature changes that we experience, on a daily basis. And I'm sure this labor force also experiences. They're out in the heat for very, very long periods of time, and then they come and they sleep in a cold environment. So I don't know. I mean, how do you, the question that I ask is from an epidemiological perspective, how do you measure this?
Yeah.
Right?
As you were saying
Is
that, I was thinking,
there
how do
data
you?
on healthy controls that what happens to their autonomic response when you move like from 20 to 50 or 20 to 40? If there is because this data can be collected in healthy controls in well-designed studies. I think that's kind of doable even in Dubai and Saudi Arabia.
So how do we do it, Dr. Vase? Like we hook them to some
Well, now
monitors
we have
like
a lot of
blood
variables,
pressure.
variables, right? So may not be in-depth autonomics, but there's plenty of wearable data that you can collect, like you said, on healthy subjects. So that may be an easy start. Heart rate variability, heart rate, all of those parameters. These may be surrogates, and then you can explore more.
This is something I keep wondering about, because the kind of strokes that we are seeing in very young people, and sometimes we don't find anything. You have this as if they have a lot of clot burden and nowhere that this is coming from. And we see so many of those now. So
But it's very well recognized. Like, I am from Pakistan, and I don't know who people understand Urdu or not. But in Pakistan, people say it's a cultural belief that garam thanda ho jata hai. If you just go from very hot to very cold, or very cold to very hot, that's risky for your
yes.
health and life. So there's a pretty well
हिकमत में
established
तो बहुत है ये.
cultural norm that something happens if you move from very hot to very cold or
Yeah.
very cold to very hot. So maybe they have some scientific basis too.
Yeah. Maybe we need to dig into that scientific basis. This temperature variability business is.
Dr. Anna has just joined. We are promoting her to become a panelist.
Fantastic.
So should we introduce Anna?
Yeah, go ahead.
Well, I would like to welcome Professor Anna Renta, who will present our last lecture, Climate Change and Stroke, a global call to action from the World Stroke Organization. Professor Anna Renta is a Wellington, New Zealand-based academic neurologist and internationally recognized stroke researcher. Her work focuses on improving stroke care quality, access, and health equity through translational research, resulting in more than 250 peer-reviewed publications. She leads the New Zealand Stroke Registry and serves as co-clinical lead for the Stroke National Clinical Network. Professor Renta is president-elect of the Australian and New Zealand Stroke Organization and holds leadership role with several international stroke organizations. She also serves on the editorial board of leading neurology journals. And it's my pleasure and honor to invite Anna Renta to deliver her lecture. Anna.
Well, good morning, everybody. Thank you so much for the kind invitation to speak, and apologies again for the technical challenges. So I'm Anna Renta from New Zealand, and I will talk to you about climate change and stroke. And I know you've already had a presentation on temperature from Maria, who was also part of this effort that I'll be talking about, but I'll cover a couple other things in addition. I know we've already been talking about increases in temperature and climate change, but just briefly, I wanted to sorry, my slides are now also acting up. But briefly, I just wanted to talk about how climate change occurs. I'm sure everyone's quite familiar with this, but there may be some people who are not so familiar. So what happens, obviously, we constantly are exposed by the sun, which is warming our planet, which is a good thing, because without the sun, it would be very cold and it wouldn't be sustaining human life. What the sun does, it sends solar radiation to the Earth, which is warming the planet. This is largely reflected, especially by lighter surfaces on the Earth's surface. These are then reflected back into space through the atmosphere. A smaller amount is absorbed by the Earth and is reflected back and usually passes back into the atmosphere, but that is impeded by greenhouse gases. Now, the problem here is that the proportion that is reflected as infrared radiation that does not pass through the greenhouse gases is gradually increasing as the planet warms. The more radiation that is trapped within the atmosphere, the warmer the planet, then polar ice will melt. Polar ice is our biggest reflective surface on the Earth that sends back the solar radiation back into space. So increasingly, the proportion of infrared radiation increases as polar ice is lost. And so we find ourselves in a positive feedback loop, because as the planet warms, we lose more and more polar ice. And as we lose more and more polar ice, more heat is trapped within the atmosphere that we've created through predominantly anthropogenic air pollution. This then has climate change effects, which we're experiencing now. So we have a warming climate. Warming climate has other effects on precipitation, humidity, wind patterns, water vapor, and these then further increase warming climate. So we have further feedback loops, and this also triggers extreme weather events. And one of the distinctions to be made here is between climate and weather. So climate is is a pattern over many years. So climate is gradually changing. We're having a gradually warming climate on Earth. But weather is different. Weather are short periods of changes within the climate, if you will, and these have immediate effects. So we have heat waves, we have floods, we have cyclones. So any of these kind of day-to-day changes that we're experiencing is weather, and that's where we're seeing some of the effects as well. So there's the overall ambient temperature increases, and I think Maria has talked some about that, and then there are the weather changes that are sudden changes in weather due to the overall climate change. Climate change has a lot of interrelated aspects to it. So we have the warming temperature, then we get droughts, then we get more desertification. This then results to wildfires and desert dust storms. We also have increased precipitation and the extreme events, and all of that then further increases climate change. So this is these persistent feedback loops that build on themselves to gradually increasing more and more effects. And so what we've done is recently published a Stroke and Climate Change World Stroke Organization scientific statement. We brought together an international panel of experts, some of them from your region, including 2 on the call here, and all but from the rest of the world. So from every continent, we've had involved people, and we also included some climate experts. So not just neurologists who have an interest in climate change and changing weather patterns, but people who are actually climatologists to give it that added rigor in that area. We looked at these weather-related stroke risk, or these risk factors, whether they're stroke risk factors or not, is something that we wanted to explore. So we looked at temperature, humidity, air pressure, dust storms, sandstorms, and wildfires. And we conducted an extensive literature search. I won't go through the detail, but we screened quite a lot of papers to end up with about 150 unique studies for full review that have been considered for this. Now, just in the interest of time, I won't repeat anything around temperature. We've already heard about temperature, and we know this is a major problem. This has certainly been the most well-researched aspect of climate change. When we're looking at environmental risk factors, air pollution is still the biggest risk factor for stroke, and air pollution causes climate change, and it can actually be exacerbated by climate change, but it's not the biggest effect of climate change. So temperature is the biggest impact of climate change, but as I mentioned before, we see other effects due to climate change. And so I want to talk a little bit more about some of those variables. So humidity and air pressure. So in all these mechanisms, and I think Maria has already touched on that, they're kind of hypothesized at the moment. There's still more work to be done exactly how these weather variables cause stroke, but humidity and air pressure seem to destabilize cerebral hemodynamics, alter vascular tone, and increase blood pressure variability, which we know is associated with both ischemic and hemorrhagic stroke. So the warming climate results in increasing humidity and barometric pressure variability in extremes. And these factors have been associated with increased hospitalizations for all types of stroke, especially during low barometric pressure, pressure instability, and rapid humidity shifts. We're seeing especially increased ischemic stroke with pressure variabilities, and increased ICH is more sensitive to pressure extremes. Now, humidity, we originally looked at air pressure separately from humidity, and then we learned that they're intricately linked. And basically, increased humidity, which is something we see with increased temperature, exacerbates all these air pressure effects. So the main problem with humidity seems to be through changes in air pressure. And the overall evidence around these associations between humidity, air pressure, and stroke are less robust than we see with temperature, but there's a clear link that we have identified through the literature. And then, of course, because heat impacts both of these factors, it's all kind of like a synergistic effect. Wildfire and fires and dust and sandstorms as well, so that got cut off there, I think, by the pictures, causes stroke presumably through air particulate matter. So it's similar to air pollution through anthropogenic pollution, so through exhaust, which generally causes an increase in fine particulate matter, so PM 2.5. Sandstorm, so the same as smoke. So a wildfire is basically like a large exhaust or a large cigarette, if you will, that is having massive impacts on our lungs. Dust and sandstorms are similar in that it's particulate matter that gets launched through our lungs in our vascular system and damages vascular walls, and increases systemic inflammation, causes autonomic activation, vasoconstriction, hypertension, tachycardia, and arrhythmias, and also increases plasma viscosity and prothrombotic environments. But dust storms and sandstorms are larger particles. So they're a little bit different, and we're still finding out exactly how small particulate and medium and large particulate matter differs in the impacts on stroke. But we do know that wildfires have definitely increased in the setting of climate change. So in California, example, there's been an 8-fold increase in the number and also intensity of wildfires between 1970s and the 2010s and 2020s. And this has had a significant short-term effect on all-cause mortality, but especially respiratory effects, which is obvious, right? Because it's affecting the lungs, just like smoking affects the lungs. But as we know, smoking and other exhaust also affects the vascular system through the proposed mechanism that I mentioned. Sand and dust storms are also increasing with desertification because you have more droughts, you have more desert, you have more wind. It's another weather change, and then you have more of these effects. And a lot of these effects are distal, far away. Now, you have deserts in your area. We actually have deserts in New Zealand as well, but we don't have desert storms. We don't have sandstorms here. But it's important to note that it doesn't just affect countries where the storms actually happen, because these particles are actually lifted up quite high into near the atmosphere, and then can travel very far distances. So it's affecting more than 150 countries worldwide. There's been meta-analyses on this, which shows increased mortality from cardiovascular disease, and a really good study in 2020 showing that Asian desert dust storms have increased stroke presentations. In the review that we did, we found that ischemic stroke seems to be more effective than hemorrhagic stroke, but overall mixed findings, so not as conclusive as humidity and barometric pressure, and certainly not as conclusive as temperature. But it does make sense that these particulate matter increases in our air would result in increased stroke. So we're watching that space, or rather, we want to make a call to action for more research in that space. Now, as I alluded to earlier, these are all very intricately linked systems. So we try to isolate things in medicine to just diabetes or just hypertension or just obesity, but we of course know they all interrelate. And the same is true with weather events. So there's these compound effects where you have a compounding of impacts from one variable with another when they occur together. So especially, as I mentioned before, temperature, humidity, and air pressure have a synergistic effect, but so does temperature and drought and reduced humidity and wind and wildfires. And importantly, it's not just that one begets the other, but when they occur concurrently, they can exacerbate each other, causing more impact than each individual factor by itself. And we identified 20 studies that looked at this specifically. So these compound effects exploring multiple weather events at once. And there's very strong, or the strongest evidence is for acute ischemic stroke, but it is a complex field. And it is something that is being explored further. It really highlights to me, as has this work done, the importance that we work with people who understand weather, because it's so complicated that it's hard for us to really grasp this as neurologists. Not that we can't intellectually, but it's just very complicated, and we need to work across fields. Then there's extreme weather events. So we know this, right? I mean, I don't know about you, but we have so many floods now. So we've had actually, it's the first time in history we had a person die in Wellington from floods. We have rain, but we don't have these massive rains. So we see these landslides, and a person just got flooded away in Wellington City a couple of weeks ago. So this is all new to us in New Zealand, these extreme cyclones, these extreme floodings. And while there's some links to infections with flooding and that sort of thing that can cause increased stroke risk, the massive impact on stroke risk is really disruption of our civil environment. So we have these floods, we have wildfires, we have various other extreme events, and they disrupt the infrastructure. So people cannot get to hospital if they have a stroke, and they cannot get to pharmacies to prevent their strokes. The other thing is with increasing sea level rises and also more flooding, which is predominantly in the equatorial areas where we're seeing most of the impacts. We're having mass migration that is occurring because people cannot live in their places anymore. There's increased tsunamis as well, and we're seeing this in the South Pacific Islands. So we're losing land mass, we're losing inhabitable places because it's getting too risky because of the increased extreme events. So we want to anticipate much more massive demographic shifts as time progresses. Now, there are especially vulnerable populations. So as already mentioned, equatorial countries are at great risk for the temperature rises. And, you know, you're much more close to the equator than I am. A lot of low middle income countries in this areas with reduced resilience. I talked about coastal lying countries. Homelessness is a problem. So when people don't have shelter and no installation, they will be affected more by heat. Age, so if you're older, you're more vulnerable to these changes. If you already have vascular risk factors, you'll be more sensitive to all of these changes. And generally neurological diseases, and you're bedbound and have these issues, you will be less likely to and able to be resilient in your systemic physiology, but also in getting help. Also outside workers, so people in the construction field who doing road construction, those kinds of things will be massively impacted by ambient temperature. And I already mentioned about refugees and immigrants. So this is a major issue. The Lancet Countdown on Health and Climate Change states that climate change is the greatest global health threat facing the world in the 21st century. But as neurologists, we don't know very much about it and we haven't taken much interest, but we are a little bit concerned, but some are not so much. This is a survey we did in Australia and New Zealand of neurologists to assess what their concern level is. And as you can see, most people think there is a problem, but a lot of people don't know what to do about it and how to translate the problem into daily practice. Now, I also point out that there's still, you see these lighter bars up here, there's still quite a lot of climate change denying out there. And this is a political issue. It's used as a political ping pong between different groups having propagandas, which is a real challenge because it's forgetting about the fact that there is a real problem that we need to address. So we need to all try to look past the politics and not make it so political, but rather just focus on the impacts of health and equip our people and our neurologists with tools to address this. So what can we do about it? So there's obviously some simple things we can do in everyday practice. We know heat is a problem, and we can talk to our patients about heat, and we can talk to them about shelter. We can talk to them about reducing sun exposure, seeking air-conditioned spaces, sheltered spaces. We can talk to our patients about win-wins. We can reduce waste. We can reduce processed food, which is energy intensive and which reduces stroke risk if we avoid it, because we know processed foods increases also dietary related stroke risk factors, as are sugary drinks. We can promote exhaust-free transportation, which is easier in some countries than others. But, you know, a lot of places don't even have sidewalks anymore and things are really spread out. And I noticed that when I was in Abu Dhabi for the World Stroke Congress, I didn't see a lot of people walking around. So we've kind of moved into these spread out landscapes. And this is a big changes, but those of us who can walk to work or can use public transportation could do that. We can advise our patients about being prepared in case there is an extreme weather event, to have a go bag ready. This is something we're doing increasingly in New Zealand with earthquakes, but now we're doing it with flooding as well. Reducing dairy consumption and meat consumption reduces anthropogenic greenhouse gases. We can try to reduce travel to conferences. We can try to reduce travel for patients, but through telehealth, and we can make a concerted effort to reduce medical waste, which is a substantial contributor to waste production and contribution to greenhouse gases. But we can do a little bit more. So these are the specific recommendations we came up with through the World Stroke Organization scientific statement. So a lot of it focuses on reducing emissions, because of course, if we can reduce the climate change, then that's the best opportunity, and prevention is always better than treatment. So, you know, as I already mentioned, clean energy, plant-rich diets, and active transport. We can also do protective effects, so we can increase green spaces, which is maybe a little bit harder in some of your areas, but maybe not all. And in urban places, we can countermand some of the effects of urbanization through increasing green spaces and exposure to green spaces, which also causes cooling. We can strengthen clinical system preparedness. We can educate our patients, as I mentioned, but we can also have warning systems in place in our documentation systems around weather events and vulnerable people. We can enhance early warning and responses, so we can be better at signaling heat waves through public health messages. We can be better at signaling air pollution increases. So just to make people aware, we can create shelters, we can have emergency response systems. And we really want to increase research and the evidence around this. It's an evolving field, and we have found that most of the research is done by public health physicians, which is fine, but they don't know stroke. And one of the big problems is they often lump ischemic and hemorrhagic stroke, and we know they're pathophysiologically different. So it's, we need to be involved in that area and also have better solutions for specifically our patients. And we want to work together globally across disciplines, across countries, because this is truly a global problem and it's affecting some people more than others that we need to advocate for. So we started out with the WSO policy statement that is you can find via that link. Now we have the scientific statement with the link here that I encourage you to have a look at for more information, detail on the scientific evidence. We could, as an organization, both your organization and the WSO, bond together with other international organizations. This is an article from some years ago, 2021, from Brain, which is an editorial of scientific organizations calling for urgent action to reduce impacts of climate change. So this is not just neurology and stroke. This is all of health. These are the countries where research is currently coming from. Most of it is from China, which is, it's great that there's so much research from China, but, there's this in your area, there are areas where we don't see any research. So we don't have that local flavor of what's actually happening in each area. And of course, it all is a little bit variable across the globe. So we want more research from more areas. So in conclusion, unmitigated climate change has significant negative impact on stroke and wider health. Complex interplay with alarming positive feedback loops, as I've mentioned a few times. WSO encourages us to become more involved by making climate change a more active consideration in our research, service development, and individual patient care, and advocate anywhere from individual to global levels according to our own spheres of influence. And I would argue as doctors, we all have a sphere of influence. So simple individual steps are a good first step. Acknowledgement, consideration, patient counseling. So let's think about it a little bit. But I would actually encourage all of us to think bigger, because the time to act is now, and we need to work together to really make a difference. And we want to advocate. And it's great we're having this webinar. We've been trying to get a climate change session at the WSC for a couple of years. We need to work together. The more we can raise the profile of that, the more we can actually have influence as people who are influential, because people trust us. And if we have the scientific backing rather than making it a political issue, I think we can really help protect our patients. Thank you very much.
Thank you, Anna. Now, if we have any questions, Debbie, can you read the questions from the chat box?
Yeah, I could. Probably from New Zealand and Australia, you could answer this. We need sun exposure for vitamin D and the role of sunscreen, for example. Is it okay to put sunscreen and take a walk or jog for 30 minutes? And maybe timing of the day.
Yeah, so I think that's a really good issue. And we have this in New Zealand. We get this debate sometimes with melanoma, actually. People say we would say as a neurologist, you need vitamin D. And then the cancer people say, no, you need sunscreen because of melanoma. That's actually a bigger issue than the temperature issue. So we do know that sunscreen does block vitamin D absorption, but sunscreen doesn't block temperature. So it's not about sunscreen. So the temperature effects will not be impacted by sunscreen. So you're fine with sunscreen from a temperature perspective. You do need to be a little bit careful with vitamin D exposure. But the way to get around this is exactly what you're saying. You do it in the off-peak hours. So you exercise in the morning and in the evening, right as the sun is not so intense. You still get plenty of vitamin D that way, but you're protecting yourself from the heat. So that's what we recommend. Don't stop exercising outside. You do need your vitamin D and you do need your exercise, but just do it at the right time of day.
Yeah, that makes sense. And I think that applies for our part of the world also. Dr. Anna, what is WSO doing? What is the role of WHO and collaborations with such organizations?
I think that's an excellent point. There's definitely WHO. A lot of our resources come from the WHO. The WHO has highlighted climate change, as a matter of fact, as the biggest challenge to human health in the 21st century. So it's an international panel on climate change, but WHO has also made similar statements on their website. So they're well aware. They're advocating for it. We as WSO has not engaged with WHO on this topic. So we are very much stuck as an organization and as a community with these individual risk factors. So we talk about hypertension. Now, hypertension is hugely important. And of course, hypertension is increased by the climate change. And that's how a lot of it is causing the stroke. But I think I see Maria and Wase, like we're trying to advocate for more of these environmental risk factors because they're completely out of control of individuals generally. And you can seek shelter and you can exercise in the morning, but as an individual, you're not going to change the climate or the weather. So you cannot, you can barely protect yourself, but we're just exposed. And it's such a big paradigm shift. People just cannot get their head around that the responsibility isn't with the patient. The responsibility is with governments. And it's become so political, and it becomes political because it is the industry funding behind this, right? Like there's the fossil fuel industry, which, is relevant to your area, and we all rely on these things economically. So it is unfortunately political. But my point really is that as organizations, we need to lead the way by changing from the individual risk factor focus, not forgetting about it, but adding the environmental risk factor focus and engaging with WHO. So that I think is a really important priority. And if, I were to stay involved with WSO, something that I would want to strongly advocate for, that we really need to start having those conversations. I'm not in that position to have those conversations, but I will take it back to the board and raise it as a topic from this if people would like me. And Maria's on the board as well, and maybe we can actually do something together. So thank you for that suggestion.
Thank you so much. We're well past the time, but Maria and Dr. Anna, any closing comments and anything specific for the MENA region? Very briefly.
No, I think I just like to thank Anna. I think it was quite an eye-opening journey just working on this climate change, statement. There are a lot of things that we feel, in our clinical practice are happening. But when you actually sit down to look at the data, I think there were many new things that I learned in this journey. I'd encourage everybody to read the statement. I think it is quite an eye-opener. And although a lot of the information that's there are just associations, because most of the studies that have come out are ecological, but they are very convincing. This is very convincing data, and data where I think we need to start taking climate change seriously. And a lot of the clinicians, neurologists, physicians are actually part of this audience right now. And I think we need to start having these conversations more often in our conferences, and I think we need to start building the data, more solid data around it with our research. So thank you so much, Anna, for being part of this. Thank you, Dr. Vase, for accepting, and you, Sebi, for being here. That's all from my side. Thank you.
Maybe I can also say, can I just actually acknowledge Wase for his work in the space, because he's taught me a lot as well, and especially around air pollution, and also Maria for the tremendous contribution she made to the scientific statement. She reviewed the bulk of the papers and did a lot of assessment of quality of the data. So this is not something that is done in isolation. It's a team effort, and you've got two leaders in the field in your community who've been very inspiring to me. So I want to thank both of you. And I just want to also emphasize further what Maria has said. If you think back, this is the problem with this topic is it's so divisive and people argue about it. But if you think back on tobacco, like we used to not believe that tobacco is bad. If you can imagine that, if you're old enough to remember that, when everyone smoked. And we used to think sugar was good because sugar is better than fat. But sugar preserves things. So industry likes sugar because it's a great preservative, just like salt. So these are things that are used for good reasons. Economics is not a bad thing. We do need to have money. We do need to produce. We do need to sustain a global economy. And fuel is an important economic aspect. But I think it's so political that people stop, they just kind of fight over it, and we just need to move forward and find solutions that work for everyone, including industry. Like we're not enemies of industry. The pharmaceutical industry, also benefits from people being sick. It's just a really complicated interplay, and I think with respect and collaboration together, we can advocate and make a difference. And if we keep bringing it back to the patient and health, I think this is our strong platform. We actually have a lot to contribute here. We're not just doctors treating a patient in front of us. We need to kind of think bigger. We're treating populations, and neurologists need to start thinking a little bit more like public health physicians. I think that's just my humble opinion, but I think soon there won't be patients left to treat with a reflex hammer. Like we need to actually think a little bit bigger. So thank you so much for this really great opportunity to talk about this important topic.
Thank you, Anna. Thank you, Maria. And before I invite Sebi for the final concluding remarks, I'd like to thank all of you for being with us today. It has been a truly informative session, and we appreciate your participation and engagement. I'd like to inform you that everyone, that evaluation form of the webinar will be sent to you within next week. Once you have completed and submitted the form, you will receive your CME certificate. So Sebi, for the last concluding comments.
Yeah, again, thank you, Dr. Anna. Thank you, Dr. Vase and Maria, and for the 300 odd participants who are still with us. Really an important topic. So I'm going to leave you with the 11th MENASO Stroke Congress is going to be held in Kuwait, and the dates are up there. It's going to be October 8th to 9th. Please do join us. It's an opportunity for us to brainstorm, meet leading experts, and probably even talk about climate over there. So thank you, everyone, for joining, and I hope to see you at the next webinar. Thank you very much, and have a good night.
Thank you.
Thank you, everyone. Bye-bye.